This came following ACCORD results. And what it said was, if you have hypoglycemia, then what it does, it immediately, as a natural defense mechanism, triggers inflammatory cytokines. It basically shoots up CRP, vascular endothelial growth factor, interleukin-6 in the circulation. Now once you have vascular endothelial growth factor, which is more in the circulation, it actually causes, we know that we have vascular endothelial growth factor is there for retinopathy, for nephropathy, etc. So these are the pro-inflammatory cytokines which go up in the system and they damage the endothelium lining of a standard vessel wall. So then we have endothelial dysfunction, and the natural vasodilatation property of this vessel is gone. Suppose you give a sodium nitroprusside here, the vessel will not vasodilate. A vessel will remain the same, if not constrict. So this is again triggered by hypoglycemia. The very important thing is we all know that if you have hypoglycemia, you have a corresponding sympathoadrenal system response, wherein you would have too much of adrenaline in the circulation, like you had more glucagon from the pancreas, more adrenaline, which is a counter-regulatory hormone, and because you have more adrenaline, your heart pumps more, so you have more palpitations, more tachy, and the tachy in a state of compromised coronaries, epicardial coronaries, which a diabetes patient perhaps, that goes hand in hand, always have, because diabetes is a cardiovascular disease. So that contractility of the heart will actually again bring in very high myocardial oxygen demand, and the patient will have angina. It will ask for more oxygen, and the workload would be more. So that might, if the patient has impending heart failure, that might precipitate heart failure. And this sympathoadrenal response with adrenaline will also precipitate rhythm abnormalities, will precipitate tachycardia, rhythm abnormalities, supraventricular abnormalities more. We also have QTc prolongation, etc. coming out of this, and this can precipitate sudden cardiac death. Hypoglycemia also, it increases neutrophil activation, it increases platelet activation and factor 7. So these all go directly into activating the procoagulation pathway, and it can actually precipitate a clot very quickly. So these are the four arms in this, in this setting of hypoglycemia that can precipitate a cardiovascular event, right? So this is very important. And because we understood this, for any diabetes patient, when we're treating, we must be really wary about not causing hypoglycemic spell. And mind you, there are papers coming in saying that a person who constantly had 3 or more hypoglycemic spells in a course of more than 2 to 3, more than 2 days, would have a high risk of having a CVD event, right? And that will be to the tune of 66%. So, if you are out of town, you're managing a diabetic patient, and the patient, he doesn't know, completely unaware, he has 2-3 unwarranted events. You never know that if you come back after a weekend, you will find him. And then you come and explain that he's a diabetic, so obviously he had a lot of complications. He had coronary artery disease. Perhaps he had a major, we say, borderline heart attack, but whether I was also instrumental in, playing the second fiddle, if not the first fiddle, in that major event, is also a consideration to me. Now, those severe hypoglycemic episodes or events in ACCORD, ADVANCE, and VALID, you see, with standard therapy, this was this. In ACCORD, it was more than 3 times. In VALID, it was 3 times. And in ADVANCE, standard and intensive, because they did not target their A1C, to very low, to lower than 6.5, they had less difference. So this was the A1C. Now see, they had 7.5 here, 6.4 here. So this was 3 times. 8.4 here, 6.9 here, they had 3 times. But this was 7.3 here and 6.5 here. So they did not have that bad. They did not have 300%, but they had only 75% more chance of death. And there you had 300% more chance of death. ACCORD study, the effect of glycemic control on the risk of severe hypoglycemia was this. the participants, with hypoglycemic events, this was standard therapy and this was intensive therapy. So this was a big chunk of people, nearly 17, 18% more who actually died. So hypoglycemic signs and symptoms, as physicians, as able physicians, we all know. First is neuroglycopenic, and then is neurogenic. Which is first or which is second? I mean, there's a lot of debate about it, but at least we can see that neurogenic is the kind of first thing that we get, because the sympathogenic mechanism starts working. Patient immediately has palpitations, tremors, sweating, etc. And then as the glycopenic, as the brain is getting less and less glucose, is getting less than 70, less than 60, then all these neurological behaviors, cognitive dysfunctions, behavioral changes, seizure, coma finally happen. Coma happens here after 30, after 20. Hypoglycemia is associated with low patient-reported treatment satisfaction and health status. Naturally, if you go by the score, this is the score. Score is called Treatment Satisfaction Questionnaire for Medication. Now, how much are you satisfied? If the score says that you are satisfied, say to the tune of 85, then you perhaps never have reported hypoglycemia. So this is no. And if it is, say, 90, then it's, even with reporting of hypoglycemia, it's 90. But what grade of hypoglycemia are you talking about? If your hypoglycemia is just mild, then it's 93 score. The higher the score, you're satisfied, better. 89 with moderate, and hypoglycemic severity, was 81%, 81 score. So, but this 81 to 100 is a big gap here in terms of treatment satisfaction. This is the EQ. EQ is the European Quality of Life standard. This is the healthcare standardized quality that we define today. This is the 5D standards. And there also we have almost similar reports. So the same kind of work. Estimated rates of emergency hospitalizations for adverse drug events in older group, the elderly group. And that you see with warfarin is the most. It's around 20, out of 10,000 outpatient department. This is the OPD patients. Out of 10,000, you have 20 patients getting admitted. Out of 10,000, you've got 18 patients being admitted with oral insulins. You've got exactly 4 number of patients with oral hypoglycemics, with oral antiplatelet agents 3. So these are the drugs which commonly actually precipitate an admission in emergency for the elderly. So the potential impact of hypoglycemia is that the likely consequences of hypoglycemia include physical and psychological morbidity, and in severe cases, fatality. Compromised physiological and behavioral defenses against subsequent falling plasma glucose concentrations, causing a vicious cycle of recurrent episodes. And how this happens? You have hypoglycemia, you try to eat sugar, your sugar the glucose shoots up. You were not taking insulin because you stopped insulin to fear. 2-3 days later, your sugar is 400. You start with that same insulin dose. It takes time to calm down. You're worried. You increase the dose of insulin. You have another hypoglycemia. So this is almost a consequential kind, suffering that a patient goes through. And hypoglycemia may preclude the maintenance of euglycemia over a long lifetime of diabetes, and therefore limits the vascular benefits of glycemic control. Now, this is a very important statement. Hypoglycemia may preclude. Preclude means prevent, stop. One hypoglycemic episode is so crucial for an individual, especially for a country like ours. If suppose some patient of yours has a hypoglycemic episode today, now, say that it's 40, you would ask him to buy a glucometer if he doesn't have. That goes $2,000. Strip, Lancet, checking, $40. Now, then you say after lunch, check and see how it is. If it's 60, then we have to do something about it. Then he reports after lunch, another $40. His sugar is somewhere around 70. You are still worried after lunch it's 70. You ask him to do at 6 p.m. and then 10 p.m. Then before dinner, do you give any medicine or what do you advise? Then by tomorrow afternoon, the sugar is almost 400 because you have been too cautious. You had also been, suffering with the patient. Now you start planning with insulin diet, oral medicines, and also keep checking whether it's kind of coming down. And the patient also is worried, so patient also sees. So after one hypoglycemic episode, an average Indian, if he's trained well, if he's empowered well with the management technique, and the doctor is adequately trained well, then between them, the patient will basically shell out 300 rupees in next 3 days, which is not peanuts. And if that is so, then that will preclude the maintenance of euglycemia. He will come back to the doctor and say, don't give me, Glynis, or glimepiride or an insulin now. Get me into something, and I'll manage with diet. 500 টাকা খরচা হয়ে গেছে এক সপ্তাহে, or 3 দিনে 300 টাকা, দরকার নেই বাবা, এগুলো তো দরকার নেই. And we're very, very common. And people like, we are kind of very aggressive, treating doctors. So we face this complicated, sad notes very often. And we now take care that we don't hear or face these problems very often. Hypoglycemia and rapid changes in glucose levels may be associated with cardiac ischemia. We all know that. And these are the data. Again, this is LC D'Souza, another fellow colleague from the same department, but this was published 7 years back. Okay, saying that these were the chest angina episodes, these were the ECG changes, etc. with hypoglycemia. And these were done with continuous glucose monitoring. They observed with an interstitial patch that as the sugar goes down, the ECG on the Holter also goes, changes. This is another good, very important slide. This is, sharing a U-curve phenomenon. The blood glucose levels at admission are associated with risk of death after myocardial infarction. Now, people who came with MI, their fasting blood glucose, if it was more than 200, the chance of or having a risk of death in 30 days, in 1 month, was around 9. And similarly, the patients who came with, say, less than 81 on admission record sugar, say 70, they had much more. They had nearly 23%, right? So, in between, if you had normal kind of looking sugar, then it was pretty low. It was around 1, 2. That is because of myocardial infarction itself. But perhaps this slide goes on to say or share the view that hypoglycemia contributes heavily to the event of death in myocardial infarction. And similarly, as this will go up, this will naturally have so much of cytokines because of hyperglycemic status that this is a U-curve phenomenon. Previous hypoglycemia may impair cardiovascular autonomic function. And this also is very important. This is baseline, and this is, the one in violet, which is not very clearly visible, is euglycemic status. And the blue ones are the hypoglycemic ones. So if you precipitate hypoglycemia in some models here, then what you saw, that your barrier reflex sensitivity goes down with hypoglycemia. After, and this was euglycemic state, you precipitated hypoglycemia, sensitivity came down. Similarly, in this model, with euglycemia and hypoglycemia, this was the sympathetic burst frequency. In just baseline, nothing was given. Then a sodium nitroprusside was given. See, the vasodilatory action is gone here. The burst activity, this is a sympathetic burst frequencies when you inject in the thigh, or in the thigh actually. Then you see with the EMG that your muscle burst activity is very prominent.